distal radius fracture. This occurred while he was snowboarding, and he was seen at urgent care 2 days prior, and then came into the ED for evaluation. He was closed, reduced, and placed into a sugar tongue splint. Next patient is a 12-year-old male who fell while playing football. He suffered a right distal radius Salter Harris 2 fracture. He was sedated, closed, reduced, and placed into a sugar tongue splint. Next patient is a 65-year-old female here for a wedding. When she fell, suffered this left distal radius fracture. She was neurovascularly intact. She was closed, reduced, placed into a sugar tongue splint, and then she will follow up in her home state. Next patient is a 67-year-old male. Took a table saw to his left long finger, suffered this tough fracture. He was able to flex and extend at the DIP joint. He is neurovascularly intact. He was irrigated and some nylon sutures were placed, and then was placed into a soft dressing. Next patient.
What do you think about that 63-year-old with the wrist fracture? What do you think about your reduction there?
Actually, it's a lot better than I thought it was going to be based on the initial displacement with that volar displacement. I think she could possibly tolerate where she's at. She is volarly tilted. She does have some radial height and inclination, but I don't know if that's necessarily going to stay where she's at. So my concern would be she's going to fall off.
Is there an eponym associated with that fracture?
A Smith.
So the point is, it's not a volar Barton, so you have a chance here, right? There's no split in the articular surface.
I was thinking more about the coronal alignment. What do you think about that?
It's off a little bit radially. But otherwise the radial height and inclination, I think it's a little flat, but I think with her age, she may be able to tolerate it long term if she were to stay there.
Well, yeah, I mean, so the inclination's a little flat, but it's really translated radially a lot. What's a landmark you use to measure translation?
My guess would be to use the cortices, but I don't know.
Yeah, so you can use the cortices. How about the ulna alignment? Where should the ulna, like the ulnar border of the ulna and the radial border of the ulna, where should they intersect the carpus?
Between the lunate and the triquetrum?
Yeah, so exactly. So the ulnar border of the ulna should intersect the triquetrum. You could see it missed, and then radial border of the ulna should intersect the lunate. So it's off quite a bit, and that's what's that going to give you problems
with? That I think probably with radial and ulnar deviation.
And what else happens?
I don't know, the pronosupination maybe.
Yes, yeah, I would say more forearm rotation, and then also the patients come and complain. You know, it's a small complaint, but they're like, "Why is my ulna sticking out so much?" Or why is this bump here?
There's a large variation though where that ulna. You're saying where the lunate sits in the lunate fossa of the radius is off?
Yeah.
I think you need to get the other X-ray, the other wrist, because I know it's supposed to be 60, 40, 70, 30, but there's a wide variation.
Next lady was a 71-year-old female that was a consult from the floor. She was actually being worked up for right cortical stroke when she was having this shoulder pain. She has complete left-sided paralysis. She is sensory intact on the left side. We found this left proximal humerus fracture, so she was placed into a sling. Next patient is an 18-month-old male. His dad was walking with him and fell under his dad and kind of rolled his ankle and his leg. He was found to have this left distal tibia and fibula fracture. He was just placed into a long leg cast. Next patient is a 66-year-old female, fell while shopping at Costco. She has a right stress negative Weber B ankle fracture. She was placed into a cam boot and made weight bearing as tolerated. Next patient is a 68-year-old female who had a direct blow and fall onto her left knee, suffered this left, mostly non-displaced patella fracture. She was able to extend without gravity. She was painful with gravity. She was placed into a knee immobilizer and made weight bearing as tolerated in extension. We'll follow up in the office. Next patient is an 84-year-old female, suffered a ground level fall onto her right hip and was found to have this intertrochanteric fracture. She has a past medical history of dementia. She was COVID positive. She was medically optimized and taken to the OR for a right hip intramedullary nail and made weight bearing as tolerated post-op. Next patient is a 67-year-old male who fell backwards onto his butt and low back. Came in mostly because he was having more tailbone pain, was found to have this L1 and 2 compression fracture and then this coccyx fracture. He was neurovascularly intact. He had minimal low back pain. It was mostly coccygeal pain, and he was given a donut and TLSO for comfort. Next patient is a 65-year-old female with a previous history of a C4 to 7 ACDF at an outside hospital, as well as bilateral total hips at an outside hospital. She suffered a ground level fall, was found to have a left hip greater trochanteric fracture, as well as a C2 teardrop fracture. She was neurovascularly intact. She was made weight bearing as tolerated on the left lower extremity with no active abduction or passive adduction. She also got an MRI, which showed some prevertebral edema, C1 to 4, with no concern for any posterior ligamentous injury. She was placed into a collar, and she will follow up in the office. And the last patient is a 53-year-old male with a history of chronic ethanol abuse and homelessness. He was found down, I believe, on the street and came into the trauma bay. He was intubated and sedated due to combativeness, and they found this T12 and L2, which were acute compression fractures. And then he also was found to have old T7, 9, 11, and L1 compression fractures. Due to his sedation and intubation, MRIs were ordered, which showed these acute fractures as well as a nerve sheath tumor. We recommended that they consult neurosurgery for this, and the patient said that he did not want any further workup and he wanted to be discharged from the hospital. And that's the end.
Good morning, everyone. First, we have a 14-year-old female, right-hand dominant. She was snowboarding. She fell and she sustained a right distal radius fracture. She was closed reduced, placed into a sugar tongue splint. Next, we have a four-year-old male presents with this left open Montasia. He underwent left ulna IND or IF with titanium elastic nails and closed reduction of his elbow. Next, we have a 17-year-old male, status post MVC. He had this left tibial plateau fracture. He was placed into a bulky knee immobilizer in the interval and then taken to the operating room for tibial plateau or IF. Next is a right-hand dominant 75-year-old female, fell down the stairs with this right clavicle shaft, distal clavicle shaft fracture. She was given a sling and made non-weight bearing, encouraged for early range of motion, passive. Next is a 53-year-old male, right hand dominant, fell off of a ladder with this right distal radius fracture. His closed reduced, placed into a sugar tongue splint. He'll follow up with us in the clinic.
So in that case, is the ulna in the right position? I mean, it looks the same as the other one. There's no lunate on the ulna here.
Yeah, I mean, Dave, my point of the other one was that, you know, even though the cortex was off,
Got it.
Your connection is bad, Jamie. On to the next case.
Got it.
We'll get the hint.
Dr. Monaco, we'll come back. We can't quite carry her right now. Next is a right hand dominant, roughly 30-year-old male. He was a trauma patient, no true age with this. He was pedestrian struck. His right first metatarsal base fracture. Metacarpal base fracture, pardon me. He was placed into a thumb spica splint.
So here's a case where the lunate is more than 50% translated towards the ulna, which in almost 100% of cases means there's a ligament injury to the wrist of significance. I don't know, what do we say about that?
So just to talk a little bit about this fracture, is this intra or extra articular? And do you have a lateral?
It was extra articular, and no, we didn't get a true lateral of the thumb, and a hand was ordered, and the patient was discharged by the trauma team before I realized.
So if this patient is treated non-operatively, what position are they most likely to heal in? And then what would be the compensatory motion that would occur more distally?
Sure. So he'll have apex dorsal or apex radial of that thumb, and his thumb MCP will be in hyperextension if it's more than roughly 30 degrees.
That's exactly right.
So, thank you.
Hey, can you guys hear me?
Yeah.
Yeah, I would just a comment, it does depend on a good AP view to make that assessment, first of all. And second of all, I mean, I think Matt nicely pointed out that you could measure the step up or the translation from the cortical displacement at the DRUJ as well. So if you're having trouble determining if it's a good AP view and you don't want to use the ulnar borders as measurements, just looking at the step off at the sigmoid notch is helpful too to gauge translation.
Hey, it's Carl. I have a question. If the radius and the ulna are fractured and it's shifted radially, doesn't the carpus translate with it? That should not affect the landmarks very much, right?
Correct.
Thank you, guys. This is a 55-year-old male. I sustained a ground level fall with this left patella fracture. I was placed into he had a significant extensor lag. He was unable to form a true straight leg raise. He was placed into a bulky knee immobilizer, and the patient elected to return and follow up for operative management, for planning of operative management.
How do you fix that?
Use a tension band fixation for him, perhaps. Next is finally a 47-year-old male. I had sustained this crush injury at work where he had this left third and fourth metatarsal neck fractures. This patient was evaluated. He was able to ambulate. He had some swelling. Watched him for a few hours in the emergency department and sent out. Weight bearing is tolerated in a hard sole shoe. Thank you, guys. Thank you.
Morning. First patient is a 65-year-old female, status post fall with a left hip intertrochanteric fracture. She's a left hip intramedullary nail. Next patient's a 15-year-old female who is a fall off of a horse with this left mid-shaft clavicle fracture displaced, and there was some tenting of the skin. She was indicated for a left clavicle ORIF. Next patient's a 72-year-old female, status post fall with a left distal tibia tib fib fracture. Underwent a left distal tibia ORIF.
Hey, Jobs, I'm sorry, just to go back to that clavicle. And I think what you did is fine, but just to talk it out, if you
Yeah.
treated the patient non-operatively, do you
Sure.
think they would have healed with a bony union? And if they didn't and healed with a fibrous union, do you think they would have been symptomatic? What are rough numbers on that?
Yeah, so you know, in this patient, I think the absolute indication for surgery would be tenting of the skin. Also, you know, fracture displacement over 100%, shortening over 2 centimeters. Those are all other numbers to look for. So non-operatively managed clavicles have a slower time to union compared to operatively managed. It's like 28 weeks in non-operatively managed versus 18 weeks in operatively managed clavicles. You also might be concerned about, you know, poor cosmesis, such a displaced fracture, although you're trading a scar for you know, deformity of the clavicle, and you would be concerned about, not so concerned in this instance, overhead endurance. So I think for those reasons, you know, in someone like this, we decided to fix it.
I think that makes sense. What's the most common operative problem that you run into afterwards?
Yeah, symptomatic hardware.
Yeah, I think that's true. The other thing I found is those supraclavicular nerves. I think you usually kind of injure some of those as you're dissecting it out, even though you try to be careful. So just below or inferior to the level of the clavicle, they may have some numbness. And if you do come back and take the plate out, well, then even there's a high likelihood of getting it then. So I think that's just something you have to mention too.
So the tenting of the skin, why are you concerned? Why is that an absolute indication for surgery?
It's mentioned as an absolute indication, I think, because, you know, you'd be concerned about some skin breakdown there. I've never personally seen that, but it's commonly mentioned in the books as an absolute indication.
Before we started fixing all these clavicles, which is a long time ago, they were many of them were tenting the skin, and I've never seen one even come close to, unless it's open, they don't come through the skin, especially in this young person.
Yeah.
Who probably has a ton of I'm sure you had a lot of periosteum. I'll bet when you made the incision, you probably, if there was no way that thing was coming through the skin, would you agree?
I wasn't there exactly when they made the incision. This happened during fracture conference, the beginning of it, so I didn't see for sure, but I believe that was the case.
Well, actually, the deltoid trapezial fascia was intact. So you're right. Charlie's right. Almost 100% of the time, it doesn't, you know, tent the skin or go through it. It's just in a thin person, very deforming with 200% displacement. But the periosteum is all stripped. It's just that the deltotrapezial fascia is not, and you have to actually open that to get down to it. But once you open it, everything is stripped for you. You don't have to do anything else. And this will heal almost 100% of the time, maybe not with bone, maybe 80, 85%, but I agree this would do okay. But you were in a time when, you know, the parents just won't allow that. And it's rare, but sometimes you can't convince them non-operative treatment is appropriate.
Not arguing with doing the surgery. I'm just saying to say that, you know, tenting of the skin to me is not a very strong indication, since I'm never worried it's going to come through. That's more.
I agree. Either way is okay, but, you know, I think it's dealer's choice.
So maybe we should write East Brunswick parents are now operative indication.
Princeton parents.
First case I have is an 18-year-old male whose status was gunshot wound to his left knee with a traumatic arthrotomy. He also had this positive arrow sign for a lateral condyle fracture. He obtained a CTA, which showed no vascular injury. The bullet was lodged in the soft tissue posteriorly, and the fracture was found to be extra-articular. He was treated with IV antibiotics and sent out on PO antibiotics and was made non-weight bearing extra-articular fracture. We'll follow up in office. Next is an 18-year-old autistic male who initially had a right shoulder dislocation 5 days prior to when we were consulted. He was closed reduced by the emergency department and sent home. However, due to his being autistic, he didn't really follow directions with his sling, and he reached overhead again to adjust the curtains and dislocated again. They were unable to get it reduced, so they called us. He was found to have this big Hill-Sachs lesion. He underwent conscious sedation and was closed reduced and put in a sling and a swath. And the patient and the father were educated about the importance of just kind of keeping him swathed until follow-up. Next patient is a 26-year-old male. He has a history of Guillain-Barré, so he has some lower extremity neurologic dysfunction. He tripped and fell and was found to have this right second to fourth metatarsal fracture. We did weight-bearing films to check for a possible Liz Frank, but those were negative. So he was made weight-bearing as tolerated in a hard sole shoe. We'll follow up outpatient. Next is a 21-year-old male. He was snowboarding, went off a jump, didn't land it and landed on his left wrist instead. He was found to have this very minimally displaced left distal radius fracture. He was put in a sugar tongue splint, and we'll follow up outpatient. Next patient is a 16-year-old male who was wrestling, and his opponent was behind him, pulling his right shoulder when he felt a pop. And he was found to have, sorry, this is in the wrong order. He was found to have a posterior sternoclavicular dislocation. Diagnosed on CT. He was transferred here for management. He went to the OR for open reduction and repair. These are the fluorofilms. Here are his post-op x-rays.
What did you repair?
I don't know. The case was during education, but I'm assuming they repaired the SC ligaments. This is a.
Do you know if they tried a closed reduction?
Yeah, we tried a closed reduction. It didn't go back in. Basically, we repaired the physis with transosseous sutures at the end.
Yeah, that was my question, because they talk about plate there staying open for a while. Was this through the level of the physis, like a Salter 1, or was it a true dislocation?
It was through the physis.
Makes sense.
This is an 89-year-old female with a ground level fall, was found to have an L1, L2 compression fractures. She was completely neuro intact. Just a little bit of back pain. She'll follow up in the office. This next case is a 14-year-old female who's playing on the playground on one of those like spinny merry-go-round things. When she fell off, she landed on her left leg. She is notably obese, about 350 pounds. She suffered this anterior left knee dislocation. She was closed reduced in the emergency room. An urgent vascular consult was placed because she had no palpable or Dopplerable pulses either before or after reduction. She obtained a CTA, which showed that she had a vascular injury at the level of the popliteal fossa. You can see kind of disappears at the level of the knee. She did have some distal runoff, and her foot was perfused. So they elected to watch her overnight, start her on a heparin drip. They did an angio the next day, which confirmed that she had an intimal injury. She also obtained an MRI, which shows that she has a multiligamentous injury, ACL, PCL, posterior lateral corner, as to be expected, as well as confirms the vascular injury. She went with vascular for a popliteal bypass, and at that time, we applied an external fixator knee spanning to stabilize her.
Why is the lateral joint so wide compared to the medial?
She had, I think, a greater ligamentous injury on the left side. Sorry, on the lateral side. She was overall stable in the X-Fix when we, applied some stressors, but I agree that the joint spaces look a little wide laterally. I don't have a great explanation other than that.
It'll usually settle even by recovery room and it'll look fine.
Fortunately, this is an injury I don't treat, but can you just talk me through what the plan is for the ligamentous reconstruction? And
Yeah.
does having the bypass change any of the treatment plan?
So I think the most important thing is obviously her vascular status and healing the bypass graft. Preliminary talks with the vascular team, they are anticipating about 4 weeks for healing of the graft and for that to kind of take and be stable enough for us to begin manipulating the knee. She'll eventually need a multiligamentous reconstruction, at least ACL, PCL. It looks like the MCL could potentially kind of scar in and be okay, but we'll, I guess, kind of reassess after her vascular status, but she'll be in the X-Fix at least, it sounds like 4 weeks until she's cleared by vascular and that's healed, until we can do our ligamentous reconstruction.
The lateral side is incompletely torn.
Yeah, she has a significant posterior lateral corner injury and
You're
LCL.
saying all 4 ligaments, both medial and lateral, is completely torn with the ACL and the PCL? Is that what the MRI shows clinically?
MCL, I think, was just like a small avulsion, a partial tear, which is why that side will probably be okay. But ACL, PCL, posterior lateral corner, and LCL were the major ligamentous injuries on the MRI. And clinically, she's more lax with varus stress, like the lateral side gaps a little bit more.
So after 4 weeks in the X-Fix, she won't get stiff, or she
She very likely might be stiff. She's young, which I think helps her. She also has an element of laxity just on her contralateral leg. I did an exam on that, and she hyperextends on the contralateral leg as well and is a little bit loose. She also has a big soft tissue envelope, but I think in somebody with a multi-ligamentous knee instability problem, being stiff maybe not the worst thing in the world for her.
This is another crazy question. I was just going to say, this is a naive question, but since she's so large and they have the whole back of the leg open, does it ever make sense to do some sort of repair initially at that time, just because it might be hard to access later?
I think that's a good question. I don't really know. I don't have a ton of experience.
It's reasonable if you have the time
Yeah.
and this to at least repair her posterolateral corner, just as a preliminary repair. That's what the guy at Geisinger does all the time. Is he'll just goes in acutely and does primary repair of the collateral ligaments and the lateral side. You don't, if you get in there acutely, you can get a pretty nice repair, and then in the X-Fix, you might get stiff, and then let the vascular thing heal, and then go back and do the cruciates electively, and then determine whether her lateral side has gotten stiff enough to leave it alone versus reconstructing. And somebody who's, obese and has hyperlaxity, all likelihood she's going to require more work, regardless of what happens when you take the X-Fix off. That's a pretty dysfunctional state for the knee.
But there is
and the other
literature
thing,
from
which
X-Fix for 6 weeks and then manipulating them and them doing okay.
Yeah, But don't you think, yeah, I think that I agree with that to an extent, but this girl, how old? She's like 14 or something like that.
Yeah, 14.
And with the
355.
hyperlaxity, I mean, that's certainly worth a shot. I'd almost leave the X6 on for longer. Like, I think 4 weeks, I'd go with 6 weeks if you can if you can keep it on that long. Maybe she's too big and it'll start to loosen up or something anyway, but the stiffer she gets, the better, but it's because Carlos is right. The outcomes of ligament repair / reconstructions in the obese are not very good anyway, so this is you are able to make her stiff, you'll be pretty lucky.
Yeah, I was just going to add a PCL avulsion would be the other acute thing. If you have a large bony fragment, may push you to do something at the same time. But, my question, I guess, and to echo Charlie's point, is the complication rate for this, it doesn't really fit the true low velocity knee dislocation, but the obese knee dislocation is pretty much 100%, right? So there's no perfect scenario here, but there's certainly leaving this alone. If you can have them stable, that's a huge win, but I think she's going to need more surgery. And then you got to talk about, what do you do? Do you do all of it all at once? Do you do your collaterals and then come back and stage your cruciates? I mean, there's a lot of variant nuances to that, but my preference to this is 6 weeks, see what is unstable, at least do their posterior lateral corner. And then if you need to, come back and reconstruct the cruciates. If you can do it all at once and you think that it's going to happen, that's great. But if she gets an infection from the lateral incision, then, now you got a whole lot of allograft tissue in there, and that's a big challenge. So this is a challenge.
It's a long road ahead of her.
About your gunshot wound to the knee, was that a traumatic arthrotomy?
Yes.
So why did that not have an IND if it was an arthrotomy?
It's a gunshot wound. There's debate. Many people don't consider it an actual open fracture or arthrotomy. So it was the attending preference to just treat it with IV antibiotics and PO antibiotics.
I know low velocity gunshot into any other soft tissue is probably fine to leave alone, but I didn't know you can leave an arthrotomy alone. Carlos, you have any thoughts on that? Is he gone?
I know a retained bullet in the joint obviously needs to be removed, but I don't know for sure that a through and through clean wound would necessarily need it. But I'm sure that there's plenty of tradition that these would get washed out.
So for those who didn't hear on the audience, Anjay pointed out there are several level 3 studies that say it's okay to leave the arthrotomy without a formal IND.
First patient is a 50-year-old male who fell from a ladder, approximately 8 to 10 feet, sustained this open right distal radius fracture. Our intern did a beautiful job reducing the fracture, had a bedside IND. I was just washing out with betadine and was taken the following day for an IND and ORIF. Next is 29-year-old male.
I'm sorry, just go back for 1 sec. The one worry I see, look at your pre-op films. Do you have a large dorsal fragment there? The pre-reduction films.
What was the question, Dr. Kopp?
So I don't know if you could hear me, but you see how you have a separate large dorsal fragment?
Yeah.
See, that's the worry where I would put my screws a little further along, where that 70% might not hold, because I'm not sure how well you captured that, big dorsal piece.
Yeah, we felt we had good fixation. We actually, one of the screws went all the way through. We measured and actually took a depth gauge and got a good positive hook in the far side. So one of the screws is actually fully across.
Okay.
We just backed off 2 millimeters.
Yeah, maybe it's just not in the exact right plane, but yeah, good one to watch. Good case.
Hey, Andrew, why is that piece important to capture?
That piece would possibly escape and you would get subluxation of the carpus.
Well, it's more so the DRUJ. So, you know, did you shuck the ulna after the case? Do the piano key test just to make sure that the DRUJ is stable? Because usually your dorsal ligaments are attached to that.
I believe we did check this distal radius. Sorry, this is 2 weeks ago. I believe we did check it. We actually compared it to contralateral side. Yes, it was stable.
So it can still shift later on as it's healing. I have one of these cases that I'm dealing with currently. Something else you can consider is pinning the DRUJ or just immobilizing in a sugar tongue. But you know, I know we talk about 75% as being equivalent to 100% in terms of fixation for these, but it's not really the same animal, because when you're talking about that dorsal ulnar corner where the dorsal ligaments are attached to, grabbing a locking screw, putting a locking screw into that is not necessarily going to keep that piece from translating dorsally and bringing the ulna with it. So it's more of a complex problem involving the DRUJ. So this is definitely a case where you could consider immobilizing above the elbow, at least for 2 to 3 weeks post-op. But yeah, this is somewhere where, I mean, the X-rays look great, but you know, these can translate later on, and when they come back at 6 weeks and the ulna's at dorsally, it's a real problem. So.
And I wouldn't be afraid to go dorsal as well, if you need to put like a little fragment specific plate on it.
Yeah. Next is a 29-year-old male who's very upset with the loss of the Cowboys. Went out driving after been drinking and hit a pole, sustained this left acetabular fracture. Ended up being more posterior wall, posterior column. Was taken the next morning for an acetabulum ORIF. Next is a 64-year-old male who is in a car with multiple of his family members who will be presented by other people. Sustained involved in MVC with this right hip dislocation, and acetabular fracture. He was closed reduced in the emergency room. CAT scan was obtained showing the posterior wall, large posterior wall piece with some comminution. More of this posterior superior dome. Was not appreciated well in the CAT scan, but we could see intraop. There was also what appeared to be a transverse component of the fracture. And so we elected to do a dual plating, the acetabulum ORF. Next was an
Andrew, did you at least let the Cowboys fan know that not to worry, at least his team's better than the Giants?
He was a little inconsolable about the Cowboys loss. So next was an 88-year-old female sustained a trip and fall with this left displaced femoral neck fracture. Was taken to the OR for a left hemiarthroplasty with cemented stem. After making the neck cut, it was appreciated that there was some comminution towards the lesser and on the calcar, so we elected to cement rather than press fit. Next is a 35-year-old male. Status was MVC with a left bimal ankle fracture. Was closed reduced and then taken following day for an ankle ORF.
Morning. The first patient is 76-year-old female, status was ground level fall, who came with left type 1 open periprosthetic distal femur fracture. The patient was initially taken to the OR for IND, and a couple of days later, she came back for another IND and revision total knee arthroplasty with distal femur replacement. Next patient is 57-year-old female, status MVC. Was diagnosed with left posterior wall, posterior column acetabulum fracture, as well as left PCL avulsion and medial meniscus rump lesion. The patient was taken to the OR for right acetabulum or IF, and decision was made to treat. It was made to treat the knee non-surgically in a hinge knee brace.
Is there a reason why, what was the reason why you, or the indication for fixing the acetabulum?
It's posterior wall, posterior column fracture. So, and there is the big piece of the posterior wall more than 50%. So we consider that unstable pattern. So that's why she was taken to the OR.
So the concept of if it's non-displaced, flexing and seeing if it dislocates or instability removes that.
Yeah, that was initially idea to take the patients for examination under anesthesia, but when attending was looking at the films, decision was made to take the patients to the OR for fixation because this pattern, according to his experience.
What does the literature say about these? Do they displace or not?
So if the fracture is less than 20% of the posterior wall, it may be stable pattern, and it's recommended to take the patient for examination under anesthesia. If there is more than 50%, like in this case, and this fracture extended to the posterior column, so our decision was to fix this.
Is that with or without dislocation?
It wasn't dislocated, or maybe it was dislocated and relocated, but when the patients came to the ED, the hip was in place. Next patient was 31-year-old female, status post MVC with left hip dislocation, posterior wall acetabulum fracture, and bilateral SI, and left-sided superior and inferior rami fracture. The patient was hemodynamically unstable in the trauma basis. She was taken for IR embolization of the obturator artery on the left side. The hip reduction was performed in ED, and CAT scan, post-reduction CAT scan revealed the bony fragment in the joint and incongruent joint. So the patient was taken to the OR for left hip open reduction, removal of the bone fragment. The bone fragment was attached to the labrum. It was reduced, and the labrum was fixed with the suture anchor, and bilateral SI screw was placed to fix unstable SI joints.
So how did you open, reduce, or which approach did you use?
We did posterior approach. We subluxate the hip, we removed this fragment, and this fragment was hanging on the labrum. So there was like a small piece of bone with the cartilage and the labrum. So when we relocated that, we reduced this fragment and fix it with the suture anchor.
Did you use a full coker or something more minimal?
We did like not full coker, but it was posterior approach to the hip. It's like a coker approach, but we went down to the acetabulum. We didn't peel the piriformis and go down to the. We just see the labrum posterior wall.
Any thought to doing this arthroscopically for that small piece?
Retrospectively, I think that's open reduction was a good idea, because this fragment there's like entire labrum and a piece of cartilage and bone attached to the labrum. It was like inside of the joint, so it was flapped. So we have to like subluxate, remove this fragment. When we, flapped it back, it was fitting perfectly to the piece of the posterior wall. I don't know. It would be difficult with arthroscope, but probably possible. I'm not
Can you
sure.
also go back one to your final films? No, go back one. No, with the post films. Is your anterior, the pubic symphysis reduced?
It's Yeah, it's minimal displacement, but we're debating to put the anterior column screws, but decision was made not to do it.
It's not more, not so much more anterior column screws. I would be worried that it's not a fracture just through the rami, but through the pubic symphysis.
I agree, there is like minimal displacement. It was like LC3.
So it's like,
the pelvis.
so what's an LC3?
So LC3 is like a SI joint on the one side, rami on the one side, and opening the SI joints and symphysis or fracture on the other side. So it's like opening on the other side.
So there's an APC component there. How would you typically treat an APC component?
So you fix it from the front. But in this
So
case,
one screw.
so in this case, it may be idea for the like plate on the anterior column that's crossing the symphysis and fixed to the other side.
Yeah, looking at the top left and then the top right, to me, something's not lining up. Something's off, and because usually with APC LC3s, you can have a vertical component, the rotational, external, internal rotation, right? So something's off there. So it's not, things aren't lining up in multiple views.
Next patient is 86-year-old male, found out in nursing home with subacute left femur fracture. Patients presented with a severe hip and knee flexion contracture. He was non-ambulatory for at least 2 years. The patient was severely demented, non-verbal. He was taken to the OR for left femur IM nail, positional nail. Next patient is 57-year-old female, status was MVC, came as a polytrauma with left humerus fracture, right calcaneus fracture, and T12 3-column fracture. The patient was treated surgically with left humerus ORIF, right calcaneus ORIF, and T10 to L2 PSIF. Next patient is 67-year-old male, status was fall from stairs with left distal radius fracture and 4th and 5th metacarpal fracture. The patient was taken to the OR for left distal radius open reduction internal fixation and 4th and 5th metacarpal close reduction and percutaneous pinning.
Do you have a better lateral of the wrist, or is that both the wrist and the hand?
If we have the X-ray of the wrist, or? Yeah, we had. I just put this to include both on the with it the wrist X-ray. Actually, the patients got repeated X-ray in 1 week, and there was maintained reduction, and we put him in the cast. Next patient is 84-year-old male, status was fall. With left femur periprosthetic fracture. He sustained hip IT fracture 2 months prior to the presentation. He was taken to the OR for left femur IM nail exchange. Next patient is an 84-year-old male, status was fall with left femoral neck fracture. The patient was taken to the OR for left hip hemiarthroplasty. Next patient is 21-year-old female, status was pedestrian stroke, who came with left open tibia fracture, segmental fracture. The patient was taken to the OR for left tibia IND and intramedullary nailing. Thank you. That's all cases from Rubberwood.
Morning.
Morning.
Morning. We
I
have
guess.
Wait, can I see your screen?
Can you see my screen or?
It says we're screen sharing.
I see
Just
Jimmy's.
your screen.
Oh, that's weird.
All right. First case, a 92-year-old female, status post fall with a left SU1 periprosthetic distal femur fracture. Taken for a retrograde intramedullary nail. Next patient, 76-year-old male who was up on his roof. He fell off the ladder with a right displaced olecranon fracture. Also with a ipsilateral both column acetabulum fracture. He was taken for an olecranon open reduction internal fixation. He also did a percutaneous anterior column screw to prevent protrusio.
Is there a piece of bone missing in the olecranon fossa?
No, I don't believe so.
Is there a particular step off?
There may be some.
Elderly olecranons are usually either more comminution or impaction.
Yeah,
Looks
there
like
was
there's
some combination. We got some good compression at the fracture site, but I guess there may be some
there's
bone loss there.
looks like there's a depressed intraarticular piece that needs to come up into that void. Is there any evidence for how old is the guy? 70?
He's 75. He's 76. So yeah, there's the Duckworth paper where they look at people over 75 and they stopped it because of more complications in the operative group. But if you look at it, I mean, the people in the operative group were on average 85. I mean, this guy, he's 76, but he's very active. So we gave him a shot. I mean, he had good skin. So.
Yeah, but I think the point is, it looks like there's a piece either missing or impacted. All you got to do is lift it up and make the joint perfect.
Yeah, I think it was missing. I mean, we looked. There was nothing really that we looked at the joint. There's nothing that we could have done.
And this was a what kind of acetabulum fracture?
It was both column. Our initial plan was to let it heal and do a total hip electively. When we were there, we were just kind of thinking that we could put a percutaneous screw there to act as a buttress or a raft almost to prevent some protrusio into the pelvis.
The screw is acting as a buttress for the femoral head, you mean?
Yeah.
So you're using the metal to hold the femoral head in place?
Well, I mean, the metal would heal in the anterior column to prevent the acetabulum to collapse and the femoral head to come through. Metal's not directly on his femoral head.
Can you just go back to the CT film? I'm just curious. So on your top right, what is that piece that's kind of gapping open, booking open there? What's usually protruded when you have protrusio after acetabulum fracture? Is it the anterior column that's preventing the protrusion, or is it the quadrilateral plate, the medial wall?
Medial wall.
Do you think your anterior column screw is holding that quadrilateral plate in place?
I don't know. I thought so, but it's not.
Look at the pelvis just to see. So unless the quadrilateral plate's attached to one of the columns, which on the top right doesn't look like it is, it's not going to stay in place. So you're still going to have protrusio. Did you close down the gap that's top, again, top right CT scan, that big hole into which the hip looks like it just wants to go right into? Did you reduce it somehow?
Yeah, we pulled some traction and we thought it looked better reduced with some traction on it and put the screw across while holding traction. That was the goal.
I doubt traction would reduce that gap. So my point is, I doubt that screw is going to help you with, if you're trying to prevent protrusion to make a total hip easier later, I doubt that's going to do anything.
Okay. Next is an 80-year-old male who was a pedestrian struck who had a left open tibia fracture. It was a 1 centimeter opening anteriorly, type 3 by mechanism. He also had a medial malfracture that was minimally displaced and a combinated fibula fracture. He was taken for a tibia IND and IM nail, as well as an ORIF of his medial mal.
All right. Good morning, everyone. Can everyone see my screen?
Yes.
Great. All right. First patient's a 73-year-old female presenting after a fall with a left proximal humerus fracture. She was neurovascularly intact, placed in a sling, will be managed non-operatively. Next patient's a 57-year-old female presenting after a fall, the right proximal humerus fracture. She's neurovascularly intact, will be managed non-operatively in a sling. Next patient's a 17.
Can you describe that fracture?
Yeah, so it looks like a 2-part surgical neck fracture.
And where is the head pointing in this case?
And
what's the translation?
So it's pointing, I guess, caudally, cranially, and it's in valgus right now.
So will this heal?
It should heal.
What factors will tell you that this is going to heal?
So I mean, it's only a 2-part fracture. You know, the medial hinge doesn't seem too disrupted. And you know, looking at like 8 millimeters of the calcar that's attached to the articular segment.
So I think that I agree it's going to heal, but the most important thing is that it's not varus. It's no more than 50% translated. And the question, to answer the question really, is to find out if she's a smoker, because those are the 3 most important things. So I think it's going to heal, but just good to know the reasons why. You know, when you're talking about that medial hinge, I don't think I mean, you're talking for the true, and I agree with that. That's more concerning if you're going to open it. But this is translated, but I think it's only translated no more than 50%, probably less.
Thank you. Next patient's a 17-year-old male, presenting after a fall with a left humeral shaft fracture. He was neurovascularly intact, radial nerve was intact. He was reduced, placed in a coaptation splint. Next patient's a 12-year-old male, presenting after a fall, ice skating, the right distal radius shaft fracture. He was neurovascularly intact, closed reduced, placed in a sugar tongue splint. Next patient's a 81-year-old male. He presented after an ejection from an ambulance with a T89 vertebral disc distraction injury. He also had a left open distal radius fracture that was presented previously. He had hemothorax and multiple rib fractures. Patient was neuro intact. MRI was obtained. Again, showing this widening of the T89 intervertebral disc and some disruption of the anterior longitudinal ligament as well. And a posterior ligamentous complex injury as well. He was taken to the operating room for a T6 to T11 posterior instrumented fusion. Next patient is an 84-year-old male. He presented after a ground level fall with a T7 3-column injury. He was found to have no sensation below the chest and no motor in the lower extremities. MRI was obtained, again, showing this injury and showing significant edema in the spinal cord at the level of T6. Again, consistent with his exam, the complete spinal cord injury. Patient was taken for a laminectomy at levels of a T6, 7, and a fusion from T5 to T9. Thank you.
This one.
Start the exponential, and maybe it'll pop up.
Can everyone see my screen, my slides?
Yes.
Thank you. First patient is a 64-year-old female, status post MBC, who sustained this right calcaneus fracture. CT imaging showing a intra-articular Sanders 3. She was originally placed into a bulky dressing, and then 2 weeks later, when the skin allowed, she was taken for open reduction and internal fixation through an extensile lateral approach. Next patient is a 67-year-old female who was originally presented in November with these injury films after a fall. She sustained this right intra-articular volar shear distal radius fracture. She was originally taken for open reduction and internal fixation in November. And then 2 weeks post-operatively, she was found to have loss of reduction with volar subluxation of the carpus. She was at that point indicated for surgical revision. However, she kind of disappeared for personal reasons, as well as COVID exacerbation. And then approximately 5 weeks later, she came back and for her revision, open reduction, internal fixation. We initially just took out the volar plate. She was essentially healed. Some of the hardware was inside of the joint, which was our major concern. And then we found that the volar lunate facet piece had essentially rotated out from under the plate and then healed kind of over the plate. So we had to osteoclase that area and then retack it down with the wire configuration that hooked into that piece to tack it down. The next patient is.
Was this one of the risks that we talked about before with that plate fixation? Because it was hard to see if any of the screws caught the styloid, or I'm trying to remember. There was a couple that were, yeah, it looks like it was the one where the screw, you see this, the radial styloid probably doesn't have much fixation. And there are plates that have little hooks built into them, or screws built into them to capture the lunate facet.
Yeah, I'm not sure. I wasn't originally in this case, if what exactly was discussed. When we were looking back in retrospect, we were talking about, maybe using like a little hook plate or some sort of fragment specific type plate would have been better to make sure that that piece didn't like rotate or migrate. But the reduction looked adequate based off of these original films. And then unfortunately that piece just migrated and rotated around. And then she disappeared before, but disappeared, and then it had essentially already healed in terrible alignment. So we just ended up bone grafting because there was like a big deficit, and she had really osteoporotic, poor quality bone.
What's the plan for spanning plate now?
So that's going to stay in place until she fully heals, probably a few months. The pins are going to come out. She has just the 2 like radial styloid pins in. We took out the one that was in the joint that was just giving us preliminary fixation. The pins are just going to stay in until her first post-operative visit.
Do you think the wrist is reduced?
As is right now.
Yeah.
Yeah, I mean, I think the carpus is not as subluxed. I think it may be just a little bit volar still. And there was this, intra-articular split from the original injury that had already healed in like malalignment. And so we didn't try to, we tried to osteoclase enough that we could mobilize that volar facet piece, but we didn't want to completely disrupt this like really thin layer of cartilage that was left. So I think the alignment that we have, the wrist is in the carpus is as reduced as we could make it.
Did you reduce the carpus first, or did you put that dorsal plate on first?
So we took everything out and reduced it first, and then we put the plate on.
How did you hold the carpus to the radius when you reduced it?
So once we took out the plate and then freed up there's like a radial styloid piece and then the volar lunate facet piece, we just put, we just used like a little small stack of towels to underneath the like distal radius part, and then using like our fingers, we essentially just like held it in place and then put then put some K-wires in and then flipped it over, went dorsal, and then we were still holding it like manually in place. So our fingers were on the volar side, holding everything in place, and then we put the plate on.
I think in order for this to work, that lunate has to be reduced. The only way I think you could do it is to make sure you have some stout pin in the lunate and the radius before you flip it over. Because if you put the plate on, the plate's not going to reduce the joint if the lunate's a little volar subluxed. And then if that's volar subluxed, it's going to be a problem. So, I mean, it looks a little volar subluxed. How old is the person?
She is 67.
Yeah.
She's not super functional. At baseline, she is basically taken care of by her much more elderly mother.
It's a tough case. Yeah.
Yeah, it was definitely tough.
That's why it's nice to have options there are company specific. The reason they make those little hook attachments for these difficult cases to prevent these complications, although they won't make it 0, but it does help to have that option available when if you're worried about that little, because this happened because of that one little piece over there that escaped and everything that went with it. So that's why you want to have those options available too.
The next case is a 70-year-old gentleman who had fallen several weeks prior and sustained this right closed ring and small finger dorsal PIP dislocations. He originally did not present acutely. He presented to the office already a few weeks out from his injury, where x-rays were performed showing these dislocations. He was brought after a couple days to the operating room for close reduction and percutaneous pinning. We'd initially just tried to do a close reduction, which was mostly unsuccessful. The ring finger was certainly easier just because there was less bayonet apposition. And then we ended up prepping the patient and then just using a towel clip to hook into the middle phalanx of the small finger, and then with some traction and then hyper extension at the joint, and we were able to slide it forward and then pin it in place.
The reason you pinned it, can you explain that? After you put it in place, what happened?
So it was, first of all, it was just very difficult because it had been out for so long. And so it was stable in mostly flexion, but when we extended it, basically when we got it into 180 degrees straight, it was very unstable. So we wanted to pin it to keep it stably reduced in flexion. And then the pins will plan to stay in for at least 2 weeks. And then we'll take them out and probably put them in a dorsal extension blocking splint where he's still in a position that he couldn't extend past his
So what position wouldn't it dislocate? How flexed did it have to be before you put those pins in?
So
did it come out at 30 degrees? Did it come out at 20 degrees? Did it come out only at 0?
So it basically would come out, like we pinned it probably in like the mid range of where it was stable. So for both of the fingers, once we probably extended it more, probably like 10 or 15 degrees more than where it was pinned, it would slide back out dorsally.
So if your goal is to get it stiff so it stays there with no motion, I mean, I think this will work. But if you're taking someone 3 weeks out and trying to treat it like it's an acute dislocation and you're trying to get it to heal, it's already healed, you didn't take any ligaments off, I think that could be problematic. So if you keep it in longer and just make them stiff, but to expect this to be either stable or have motion, I don't think that's probably going to happen.
Yeah, I think we expect him to just be very stiff, especially because he presented, so many weeks.
I don't think that's a crazy idea. I mean, he's just going to be reduced and won't have pain, but he's in good flexion, so that's pretty good. But I wouldn't expect much motion here.
Right.
And I think I'd probably pin it longer.
More than a couple of
I mean, if you take it out too soon, he's going to redislocate.
Right. And that's it. Thank you.